pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Welcome to the September 10th, 2025 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and also accessible by Zoom. I ask that you please use the system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Carol, please take the roll.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee.
Present.
Director Stewart.
Present.
Director Epen.
Present.
Mm-hmm.
Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Or are there any written communications?
There are none.
Thank you. We want to
Consent.
go to that. Okay.
Yeah.
We will now move to our consent calendar. Consent calendar consists of those items that the board would approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any of the items are removed from the consent calendar, the board will take action on the removed item later in the meeting under the action item heading on the agenda. Anyone on the board wants to remove an agenda item from the consent calendar? Any member of the public wants to remove an agenda item from the consent calendar? May I have a motion to approve the consent calendar item A?
I move that the Board of Directors approve consent calendar item A.
Okay.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye. There's a reason why we do that with one item. It takes more time than just approve it.
Action.
Tradition. Okay. What's the next?
All right.
Move to the press.
We have two presentations this evening. We're going to start with Joanne Pineda, and she's from the American Heart Association, and I'm going to give a little bit of a background on Joanne, though she is very familiar with us. She has been with the American Heart Association for 20 years, with over 10 years of quality improvement experience. She is currently a program consultant for healthcare on the Heart Association's Quality Outcomes Research and Analytics team. She will be presenting 2 awards this evening to Washington. These awards demonstrate the true collaboration and coordination among departments, staff, and physicians. Everyone's efforts have saved lives, reduced suffering, and have always focused on the patient-first ethic. So it's my pleasure to have Joanne here with us this evening, and so I'm going to turn it over to you.
Thank you. I think you're getting the presentation up. Yes?
Yes. Yes. Can you see it now?
I can. Well, good evening. My name is Joanne Pineda. I'm a healthcare quality consultant with the American Heart Association. And on behalf of American Heart Association, it is a privilege to be here this evening to honor your achievements and to celebrate with all of you. Next slide. Get with the Guidelines puts the expertise of the American Heart Association and the American Stroke Association to work for hospitals nationwide, helping ensure patient care is aligned with the latest research and evidence-based guidelines. Washington Health actively participates in 2 of our programs, Get with the Guidelines Coronary Artery Disease and Get with the Guidelines Stroke. These in-hospital programs improve stroke and cardiac care by promoting consistent adherence to these guidelines, which can minimize the long-term effects of a stroke or cardiac event and even prevent death. The American Heart Association is pleased to present awards for quality stroke and cardiac care delivered by your hospitals to the patients within your community. And we congratulate the members of your clinical team and the work they do every day. Next slide. Washington Health has received the American Heart Association's Get With the Guidelines Coronary Artery Disease STEMI Receiving Center Gold recognition for its commitment to offering rapid research-based care to people experiencing a specific type of heart attack known as ST elevation myocardial infarction, known to be the more severe and dangerous types of heart attacks. Recognition as a STEMI receiving center is designed to showcase hospitals that provide 24/7 support for STEMI, and these important facilities, like your hospital, coordinate with a network of referring hospitals and EMS agencies to service, to provide guideline-directed STEMI and STEMI care. So led by Dr. Terrence Lin, the STEMI team continues to provide stellar care, earning the Get With the Guidelines Award recognition year over year since joining Get With the Guidelines coronary artery disease in 2020. And based on the team's exceptional performance in 2024, as mentioned, Washington Health received the 2025 Get With the Guidelines Coronary Artery Disease STEMI Receiving Gold with Type 2 Diabetes Award. Now on to stroke. Led by Dr. Jack Rose and Dr. Prabhat Khalsa, the stroke team continues to provide exceptional care, earning Get With the Guidelines Award recognition since participation in 2005. Based on the team's stellar performance in 2024, Washington Health has achieved the 2025 Get With the Guidelines Stroke Gold Plus with Target Stroke Honor Roll Elite Plus with Target Type 2 Diabetes Honor Roll Award. The Get With the Guidelines Gold Awards recognize hospitals that treat 85% of eligible patients according to the AHA's recommended guidelines for 2 or more consecutive calendar years. Adherence to these evidence-based guidelines, they save lives and improve patient outcomes. The plus level requires additional data collection for a set of quality measures at 75% or above compliance. The Target Stroke Honor Roll Award, I think one back. The Target Stroke Honor Roll Award is presented to a very exclusive group of hospitals, both in California and nationally, that treat at least 75% of their acute stroke patients in 60 minutes or less, providing the patient the opportunity to receive a clot-busting drug, which has been proven to improve outcomes for the stroke patient if given within a short period of time after symptom recognition. And then lastly, next slide, Washington Health received the American Heart Association's Target Type 2 Diabetes Honor Roll Award. Type 2 diabetes aims to ensure patients with type 2 diabetes who might be at higher risk for complications receive the most up-to-date evidence-based care when hospitalized due to stroke or STEMI. Next slide. In addition to each hospital staff's touch point with the patient, the system of care does play an important role for patients to receive the best care. Get With the Guidelines captures key metrics for every step in the patient care process, from EMS to in-hospital to discharge, and to ultimately have the greatest impact in care. Get With the Guidelines supports the overall system of care, which is critical for reducing mortality and morbidity. We all know that time is brain, time is muscle. We know that everybody wants to do their part, and everyone has a meaningful contribution to the entire patient's care process. And the patients and families in your community are incredibly thankful for that. So thank you. Thank you to our stroke and cardiac champions. Get With the Guidelines, we emphasize a multidisciplinary team approach to patient care. Thank you again to the stroke leadership team, Drs. Rose, Khalsa, Maria Noon, Charlene Singer, and the STEMI team leadership, Drs. Lynn, Bati, and Alvin Aguirre. In addition to the stroke and cardiac leaders, I'd like to extend our gratitude to the countless champions in the ED, the ICU, telemetry, medical surgical, cath lab, data analytics, and executive quality nursing leadership, everyone represented at today's meeting. The recognition reflects not only the hard work and dedication of the team, but also the collective commitment to providing exceptional care and improve the quality of your stroke and STEMI patients. As in prior years, the Heart Association celebrates your hospitals alongside all silver and gold award-winning hospitals nationally. Next slide. You'll be included in local and national recognition by the Heart Association with a listing on our and inclusion in the America's Best Hospitals edition of U.S. News and World Report. And then recognized at our annual national conferences such as International Stroke Conference and scientific sessions. Next slide. So it is my pleasure this evening to just celebrate with all of you and present the Get With the Guidelines Coronary Artery Disease STEMI Receiving Gold Award and Get With the Guidelines Stroke Gold with Target Stroke Honorable Elite Plus to your hospitals. Thank you again for your outstanding commitment and dedication to quality stroke and cardiac care. Congratulations.
Thank you, Joanne. Thank you. Any questions?
Just a comment. As Joanne said, and she really highlighted all the team members of the team. This is really a team effort to achieve these kind of results. And I think what we have to recognize is that achieving these goals actually results in better patient outcomes. So that's the end game. That's better outcomes. Getting them out the door healthy and happy.
Really part of one team.
Exactly.
Mm-hmm. Yeah. Great job. Great.
We look to seeing you back next year, Joanne.
Yes.
Thank you.
Thank you.
Congratulations.
Thank you to
Good night.
everyone.
Thank you.
Yes.
Okay.
All right, we have another presentation. We have Angus Cochran, our Chief Community Support Services, and Kayla Gupta, our Community Outreach Manager, who are back presenting this evening. They are following up to the Community Health Needs Assessment that was presented a couple months ago, and they have now the Community Health Improvement Plan for fiscal year 26 and 28. I just want to briefly introduce them again to everyone. Beginning with Angus Cochran, he's our Chief Community Support Services. He has been at Washington Health since 2006. And in this role, he is responsible for government relations. He's also the liaison to the Service League and manages community outreach and the Health Insurance Information Service. He earned a bachelor's degree from UCLA and a doctorate from Columbia University. Also joining him is Kayla Gupta, our Community Outreach Manager. She has been with us since 2022. She is responsible for all of our health and wellness programming and the Washington Wellness Center. Before joining Washington Health, she worked with Sutter Health as a community benefits coordinator. In this role, she managed the community health needs assessment and grant making in San Mateo and Santa Cruz counties. She earned her bachelor's degree from the University of Pennsylvania and master's degree in public health from Emory University. Kayla is married with one very cute young boy. We've seen a few activities, so I'm going to turn it over to you.
Well, thank you so much for that kind introduction, Kimberly. I'm sorry, we don't have an award to present this evening, so we'll instead we have a PowerPoint presentation with our Community Health Improvement Plan. Thank you for having us back, members of the board, to talk about the 2026 to 2028 Community Health Improvement Plan. This is a 3-year plan that lays out the scope of work we're proposing in response to the findings that you learned about earlier this year in the 2025 Community Health Needs Assessment. Before I turn it over to Kayla to go into the details and present the plan, I just want to make a couple of points. We developed this plan with all of our colleagues in the clinical areas. They have been so generous with us in lending us their expertise and their time and coming to community events with us, and we're very grateful to them. The plan is intentionally meant to be flexible and adaptable so that as conditions change over the next 3 years in the district, the plan will change along with it. Second, we've really chosen to highlight a number of the most impactful initiatives that are underway or that we're planning. It's not an exhaustive list of everything the organization is doing to improve community health. There are many initiatives underway that are not actually included in this presentation. And at the heart of the CHIP is collaboration. It really is working with our internal partners, community-based organizations, the faith community, and the cities in the district, and local agencies to reach populations that have particular health challenges. And finally, as you'll hear from Kayla, we will be focusing our work on 6 of the most pressing health needs in the district. These are the areas we feel we can have the biggest impact. The other areas we will address through partnership and through research, but we really need to focus our efforts on the places where we can make the most difference. With that, I want to turn it over to Kayla, who will walk us through the plan. And then after the presentation, we'd like to ask the board to formally accept the findings of the health improvement plan. Thank you. Take it away, Kayla.
All right, thank you so much, Angus, and thank you all. I'm very honored to be back again to present to you all our 2026 through 28 Community Health Improvement Plan. All right, so today we're going to start off by reviewing the key findings of our 2025 Community Health Needs Assessment Report. I'll then outline our Community Health Improvement Plan for the next 3 years, and then we'll request a board action to accept the 2026 to 28 CHIP report. The board did approve our 2025 CHNA back in June, so a lot of the information that I'll go over in the first part of this presentation will feel very familiar to you. So why do we do a CHNA and a CHIP? Our CHNA really helps to provide important insights into the health of our community. And this work is what allows Washington to develop a community health improvement plan that tackles the most critical health needs of the district. Moving on to the next slide. We can see some of the key findings from our 2025 Community Health Needs Assessment. So these were the top 10 health needs that really rose to the top as having the largest impact on the health of our district residents. So these top 10 needs were economic security, behavioral health, healthcare access and delivery, inequity and discrimination, cognitive decline, diabetes and obesity, heart and stroke, cancer, infant maternal health, and unintended injuries. And the board voted to accept these findings in June, and our full 2025 CHNA report is now currently available on our website. So let's take a moment just to quickly review the overall health of our district. This slide shows a bird's eye view of all of the health indicators across the 3 cities and how they stack up against the county. So the 0% vertical line that you see represents county incidence. All of the bars to the left show where a city is doing better than the county, and then all of the bars to the right show where a city is doing worse than the county. So for the green bars for Fremont, we can see that 93% of those health indicators are the same or better than the county. Looking at Newark, in the orange bars, we see that 80% of our health indicators are the same or better than the county. And then lastly, when we look at Union City with the yellow bars, they only beat the county average for 56% of those health indicators. Let's look a little closer at the 5 indicators where Fremont's doing worse than the county average. So we see that emergency department visits for Alzheimer's and dementia are 25% worse than the county average. Other areas where Fremont is falling behind the county are conditions related to heart, stroke, and unintended injury. Moving on to Newark, we can see that there's more conditions that are worse than the county. Infant mortality rates are almost 50% higher than the county rate, and other measures on this list are associated with heart disease, stroke, diabetes, and obesity. Finally, we see that Union City residents struggle more with their health than other parts of the district. 31 health conditions are worse than the county. We also saw this in our 2023 cycle as well. And similar to that cycle, most of these conditions are related to heart and stroke. But we also do see infant mortality rates that are around 50% higher than the county as well. So as Angus mentioned in his introduction, the CHIP doesn't focus on all 10 of these needs that come up in the CHNA. Instead, we've created 4 areas of focus that encompass about 7 of those 10 needs where we feel like we can have the largest impact on the health of our community. And so these areas of work will be healthcare access and delivery, healthy lifestyles, which is our widest, broadest category of work, and will encompass things that affect diabetes, obesity, heart, stroke, and cognitive decline, cancer, and then unintended injury. And so for the rest of this presentation, we're going to take time to dive into the programs and the work that is planned to support each of these areas. Before jumping into programs that support healthcare access and delivery, I just want to quickly review the findings from the 2025 CHNA. So when we look at insurance rates in the district, we find that our district residents are really well insured. However, despite having good insurance coverage, there's a trend where we're seeing an increasing trend with difficulty in accessing care. About 25% of the population reports delaying or having difficulty obtaining care. And with changes to the federal healthcare policy landscape and the passage of HR 1, we expect that issues to access will increase as more residents lose insurance coverage. It's also important to note that there's an emphasis from community members on the importance of receiving culturally relevant care in proper language. So this following slide here outlines the work that Washington Health is already involved in that's having a positive impact on healthcare access. So keep in mind, this list is not exhaustive, but it does talk about some of the highlights. So Washington Health invests time engaging with our community as part of our Health Equity, Diversity, Inclusion Council. We ensure that many diverse voices in our community are heard. And now that we have a Patient Family Advisory Council and Community Advisory Board, this is a great way for us to engage with dialogue with our district residents. Another way that we've increased access is through the opening of our Trauma Care Center, which allows patients to receive the highest level of care close to home. The other bullets on this list you may be familiar with as well. We work really closely with community partners to underwrite programs and offer financial assistance to patients in need. Looking forward, we have 2 new capital projects underway that will help increase access to healthcare services. The first is our Urgent Care Center, which is planned to open this year. And the other is the development of our Warm Springs Outpatient Center, which will extend services to residents in the southern part of the district. Internally, we're also focused on committing resources to increase the cultural competency of our services for people of all backgrounds. This includes staff education, translation services, and offering health education in other languages. The final 2 items listed here, we really intend to strengthen relationships with external partners to ensure seamless transitions of care. So now we'll move on to our second area of focus, which is healthy lifestyles. So as we know, there's a lot of health needs that can be improved by district residents making healthy lifestyle choices. By investing in and promoting healthy lifestyle programming and education, we can have a positive impact on health conditions like heart disease, stroke, diabetes, obesity, and cognitive decline. Our focus groups and interviews with community members show that there's great interest in this kind of programming. Access to increased recreation programs, nutrition education, and supportive disease management all come up when we speak with the community. And when we look at the data, we see that diabetes prevalence continues to increase year after year, almost doubling in the last 14 years. Diabetes rates are consistently worse in the healthcare district than the county. Moving on to the next slide, we can also see that cerebral vascular conditions continue to be a great concern in the healthcare district. Issues such as heart disease, stroke, and heart attack are among the top causes of death in the county, with Union City and Newark having the worst outcomes in these categories. So this chart here really illustrates our growing concern for Newark and Union City. Almost all of the indicators on this table are worse than the county by 5% or more, which is represented by those orange shaded boxes that you see. So what are we doing about it? A lot of this work really comes down to educational programming, support groups, and partnerships. In just the last 2 fiscal years, we've provided health education at 160 events, which includes things like health fairs, our speakers bureau, and special events. This equates to roughly 17,000 interactions with the community. And this work is taking place across the entire district through all of our 3 district cities. Since our last CHNA and CHIP, we've created a strong partnership with the City of Union City on our Heart Smart Walking Challenge, and I'll talk more about that program in a bit as well. Let's take a look at where things are going. The community outreach team is exploring the idea of hosting a healthy lifestyles community health fair to highlight health education and resources. We know that many healthy lifestyle habits start in childhood, and so we're looking to expand our partnership and outreach in schools. We'll also continue to develop partnerships with organizations working with racial and ethnic groups where we see large disparities in health outcomes, such as diabetes for our Latino population. We're really proud of the work that we've done in Union City on our Heart Smart Walking Challenge. This slide just wants to highlight some of that work. So this program was created in direct response to our 2023 Community Health Needs Assessment. And since we kicked off the program in February of this year, we've registered over 190 walkers and logged 46 million steps and counting. We now feel like we have a really strong program and a model that we can roll out throughout the district, and we're looking at exploring expansion into Newark in the coming years. Our third area of focus is cancer. So in 2022, cancer was the #1 cause of death in Alameda County. If we slice and dice the data by race and ethnicity, we can again see that our Black population, the blue bars in this chart, are disproportionately impacted by the condition, especially in Union City and Fremont. Cancer mortality rates for the white population in all 3 cities are also higher than the county's rate. Looking at cancer mortality and hospitalization by city, we see that lung cancer mortality is highest in Newark and colorectal cancer hospitalization is highest in Union City. Union City also has high rates of breast cancer hospitalization, rates that are higher than the county. Central to our ongoing cancer work is our partnership with UCSF. This partnership gives our district residents access to the latest technologies and clinical trials. As you can see in this slide, we have a robust set of educational programs, events, and screenings around cancer. Some of the highlights of this work are our annual Think Pink breast cancer awareness event and our annual free skin cancer screening program. For new cancer initiatives, the UCSF Washington Cancer Center expansion will have some of the largest impacts. This new center is set to open early next year, and it increases the capacity of our infusion center. We'll also have the addition of a new oncologist, which allows us to see more patients overall. Our outreach team is going to pursue strategic new partnerships with organizations that serve racial and ethnic groups that we see are disproportionately affected by poor cancer outcomes, like our Black population. Our fourth and final area of focus is unintended injury. So unintended injury includes things like falls, motor vehicle accidents, drownings, and pedestrian-related injuries. And it's the #1 reason for preventable emergency department visits. You can see this chart on the slide right here really drives home that point. So it's very timely that we opened our trauma center last July. Our trauma team has done an amazing job treating the over 2,200 trauma cases that have come through our doors since opening last year. And even though we have the skills and expertise to treat these challenging patients, a cornerstone of the trauma program is community education, because the hope is to teach you skills to prevent injuries before they happen. Our trauma outreach team partners with nonprofits and local organizations to offer injury prevention trainings on a variety of topics that you can see listed on the slide. These classes are offered throughout the entire district as well as on our campus. The trauma team also works to create stronger screening and referral programs to ensure proper continuity of care after injury. And we're already busy working on future initiatives for injury prevention. On Saturday, October 4th, the Trauma Center team will be hosting a community safety fair on site at Washington West. This family-friendly event will feature over 20 community resource booths, as well as a bike rodeo and on-site emergency vehicles like police cars, fire engines, and ambulances. We really hope that you'll join us in the fun. Looking further into the future, our trauma outreach team will continue to build partnerships with community organizations and EMS to expand their impact to more members of our community. We've already begun working and partnering with EMS, but there's always more work to be done when developing our work together. Some health needs, as Angus mentioned, are best addressed through partnership. So the first health need where this is true is economic security. It's our feeling that one of the most effective ways to contribute to the economic security of the district is by working with a wide variety of advocacy groups that focus directly on aspects of this work. So the list here shows organizations that Washington Health partners with on financial support, volunteer leadership, service projects, and technical expertise around health education. When we look at behavioral health issues, we can just back up one quick second. There we go. When we look at behavioral health issues, we already have a large amount of organizations that are listed on this slide that we work with in the district. And Washington Health maintains an open communication line with all of these partners by convening our South County Partnership on a bi-monthly cadence. The mission of the South County Partnership is to advocate for greater behavioral health resources in the Tri-City area. So we understand how important behavioral health is to the community, and over the past 2 years, we've focused a lot on this need. This past summer, we hosted our first ever behavioral health symposium and fair, which reached over 150 people and brought representatives together from over 20 different organizations. We're planning to continue our work in the emergency department with the Hume Center and their behavioral health navigators. This in-house outreach team has significantly increased continuity of care for patients suffering from mental illness and substance use. Washington also continues to have a strong presence at community events, with Dr. Seema Sehgal chairing this year's NAMI Walk. Really, what all these activities illustrate is how much we can accomplish through collaboration and partnership. One thing that we did not expect to find in our 2025 CHNA were such great disparities in infant mortality rates compared to the county. Infant mortality rates in Newark and Union City are almost 50% higher than the county, and this is very concerning for us. It's going to take additional research for us to understand what's caused this trend to emerge. Washington plans to further explore the findings of the CHNA through collaboration with the county and local FQHCs. Internally, we also have great resources through our medical group, the maternal and child health, and labor and delivery clinical teams. Just as a point of comparison, Washington Health has a much lower infant mortality rate of 0.81 per 1,000 births. This is about a fourth of the county average. And we're also designated as a baby-friendly organization. So this area of study concludes the work outlined in our Community Health Improvement Plan over the next 3 years. As you can tell, we do have a great deal of work cut out for us, but we look forward to coming back to the board and reporting out on our progress in the future. So I want to thank you so much for your attention. Before we take any questions, I also just wanted to make sure to thank all of our clinical teams for their commitment to our community work, the PCS team, diabetes, oncology, trauma, and stroke teams. Really, without their partnership, this would not be possible. And I'd also like to extend my thanks to Kimberly, Tina, and the entire board for being so supportive of our Washington Health outreach efforts. So with that, I'm happy to take any questions you may have.
Thank you. Thank you, Kayla. Board members, any questions? A lot of work to do.
Yeah, a lot of work. Good things in the community.
Yeah.
Thank you, Kayla.
I want to thank Kayla for all this. This is largely her work, and she has poured her heart into these documents and into the work in the community. I think she's actually been at most of those 160 community events herself and shaken those 17,000 hands. So I really, we're lucky to have you here, Kayla. Thank you for everything you've done for us.
Thank you. Thank you. Okay, at this point, I think we're going to consider the action item related to the improvement plan.
Okay, Mr. President, I move that the board adopt the Community Health Improvement Plan for FY 2026 through 2028.
Second.
A quadruple.
Okay.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen.
Aye. Thank you. Thank you all. Thank you, Angus and Kayla. Really appreciate your work.
Thank you.
Thank you for all your hard work,
Yes.
and I know it takes everyone working together to be out in the community so much. So thank you both and everybody that participates.
This is one of the most impactful, wonderful things the hospital does.
Mm-hmm.
Yeah.
I think very few people are aware of it.
Well, we will work to change that. Thank you, everybody.
I was just going to say, I know they will work, and I know we need to continue to get the word out there.
Right.
one of the things, Kayla and Angus, I think we should have in forefront is now the vaccines. There's so much of turmoil on this vaccine and disinformation on this vaccine. So the vaccine uptake, I think it's only below 90%. I think there are a lot of studies to show that under this more than 95%, you don't get the herd immunity. And if that falls, I think we are in trouble. And that's exactly what happened in western Texas and southern Oklahoma and all those places where they had this epidemic of measles. And we are not far from it. So I think we've got to keep really our eyes on this. And probably vaccine should be definitely one of the indicators that you should be looking into it. And it was also interesting to see that although the incidence of heart-related or cardiac-related cases were highest in Union City, the mortality rate was much lower than Newark. Makes you wonder whether people in Union City are more educated, and so they are getting hospitalized earlier than Newark. I mean, that's the only explanation that I could think of. But if you look at the mortality rate, Union City is lower than Newark. And the third thing would be the diabetes. If that incidence of diabetes is high on the white population in Union City and Latinos in Fremont, I think it would be good to have a classification in that, not just the incidence of diabetes, but how many of them or what percentage are controlled or who are getting treated. Because there's a vast difference between the two. If 99% of the diabetes are controlled, then I don't think it's much of a concern. But if more than 50% are not controlled diabetes, I think it is definitely, we are setting up for trouble. That's all. Anyway, great presentation. Thanks.
Thank you.
Thank you.
Thank you for your thoughts, Director Eapen.
Okay, we're going to move to the report.
Right. And this evening we have Dr. Jeannie on. She's the Chief of Staff-elect for Dr. Berry, who is out this evening, so she will be presenting.
Okay, good evening, everybody. I'm Dr. Jeannie Ahn. I'm serving as Dr. Berry's avatar tonight. So I'm going to present to you the medical staff report. So we have 8 new physicians who have joined the staff. Dr. Luis Alvarez, who joins as a nephrologist from Palo Alto Medical Foundation. Dr. Jonathan Jong, who's joining our emergency room department. And we have 2 stat-rad radiologists, Dr. Jonathan Cole and Dr. Brandon Campbell. Dr. Alexandra Paul and Dr. Julian Rizos are orthopedic surgery fellows from UCSF. And our last 2 physicians are Dr. Zaina Sadiq, who's joining as a hospitalist, and Dr. Abhishek Saluja, who'll be joining our anesthesia department. So overall, our staff total is remains at 668, of which 374 are active members, 39 are APP, 102 ambulatory, 67 are provisional active, 8 are provisional advanced practice providers, and 53 are provisional consulting. The majority of those are teleradiology doctors. So next month, Dr. Berry will introduce our 9 new physicians who are coming on staff, including a actual radiologist, not a teleradiologist, but a diagnostic radiologist, a urologist, a new critical care intensivist, and trauma is finally getting their wish. A new trauma nurse practitioner will be joining the staff. So stay tuned next month. In addition, we had 2 we had orthopedic surgeons who are applying for robotic privileges, including Dr. John Kostoros. There are currently only 5 programs in the world who use the robotic surgery for advanced shoulder surgery, and Washington Hospital will be the 6th. So we are blessed to have that kind of expertise at our door. A last thing I want to mention is we had a medical staff event on September 8. It was a luncheon featuring Mediterranean food. It was an opportunity for the physicians to meet each other in person instead of Zoom and to recharge before going back to their clinics or rounding in the hospitals. So that's my report. Thank you for your time.
Well, thank you, Dr. An. Any questions or comments?
Good job.
Thank you.
Our next is our Service League report. Sheila Vijay, our Service League president.
Oh, hello. Good evening, everyone. Members of the district board, I extend warm greetings on behalf of all the volunteers. In August, 286 Service League volunteers contributed 2,951 hours of service across various hospital departments. On September 7th, we welcomed an enthusiastic group of 19 volunteers to orientation, with 4 high school students, 9 college students, and 6 adults. We were able to interact with each attendee and address their questions individually as they learned about hospital protocols, Service League expectations, and the many ways they can support patients, families, and staff. The final session of the WOOF Pet Therapy Education Series will be held via Zoom on October 10th from 12 noon to 1 p.m. Dr. Gina Cardwell will present on the topic, Raising a Happy and Healthy Puppy. It should be an enlightening, interactive talk for those with new puppies and for anyone interested in learning more about raising a happy, healthy dog. Speaking about the WOOF program, on Thursday, September 4th, at the weekly meeting of the Niles Rotary Club, Russ Weinberg, coordinator of the Service League WOOF Pet Therapy Program, introduced this volunteer role and answered many questions from club members. Russ was introduced by WOOF volunteer and club member Jeffrey Barnhart, who was also accompanied by his canine companion, Royce. And Royce was obviously the real star of the show. Lastly, I'd like to highlight the ongoing music volunteer program. At present, the program includes 5 high school students, 2 college students, and 1 adult volunteer. These talented musicians play for visitors and families in the main hospital lobby and also in Washington West. Recently, Abigail Uy, one of our college volunteers, shared a memorable moment she experienced with visitors while playing the piano. Earlier today, she says, I had the opportunity to play piano in the lobby and wanted to share a few heartwarming moments with you. A gentleman, teary-eyed, stopped to listen as I played a Disney piece. When I finished, he told me that the piano I was playing had been donated by his late grandmother, a gift that continues to bring joy and comfort. Shortly afterward, another visitor, a woman, shared that one of the pieces I played had been her father's favorite. Moments like these remind me, Abigail says, why I love playing music here. It connects people, sparks memories, and brings comfort. Even as I continue my nursing studies, I hope to keep playing the piano at Washington Health, and I'm grateful for the chance to share it through the Service League volunteer program. As you all can see, our volunteers, whether they are 2-footed or 4-footed, bring lots of joy to our community in many, many different ways. That concludes my report. Please let me know if you have any questions.
Thank you, Sheila. That was a very heartwarming report.
Thank you.
Any questions? Thank you, Sheila. Good evening.
Thank you. Thank you, Mr. Rob.
Thank you, Sheila. All right, next we're going to move on to Dr. Diane Martin. She's our infectious disease program consultant. And I know thank you, Dr. Ethan, for bringing up about vaccinations and the importance of that. And I think she is going to be talking about the upcoming influenza season and what to think about in terms of that. So let me just introduce her. I know that she's very familiar to many of us. Dr. Diane Martin worked as a member of Washington Hospital's medical staff from 1980, or part of the medical staff from 1984 to 2023. She's held many leadership roles at Washington Health. Since retiring from Washington Township Medical Group in 2023, Dr. Martin has continued her role as the Washington Health Infectious Disease Program Consultant. She serves as the chairperson for the Infectious Disease Prevention Committee and chair of the Antimicrobial Stewardship Program. She attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine. Welcome, Dr. Martin.
Thank you very much. Thank you for that introduction. So what this presentation will do is to review three current circulating viruses, which is influenza, COVID-19, as well as respiratory syncytial virus. And I want to update some changes in the vaccine updates, as well as emphasizing what Washington Health is doing to protect our patients. I'll also go over some common questions and what we're doing to promote our health in general. And if somebody can drive the slides for me. So our 2025-2026 influenza will be probably co-circulating both influenza, COVID-19, and respiratory syncytial virus. And I'll be talking about each one of those individually. What we want to emphasize is updated vaccination is needed almost annually and remains the primary strategy for reducing severity of infection and preventing any ongoing infections. This discussion is focused mostly on adults and the community-based recommendations. So I'll have a few notes on pediatrics, but that's not my specialty. So the vaccine updates that we're going to go over is influenza. Influenza protects against two strains of influenza A and one of influenza B. And this season's vaccine, compared to last year, has been updated with one of the A's to an H3N2. The recommendations of further vaccination updates are pending some of the FDA recommendations, and we're waiting to hear from that. Probably mid-September is when we're going to get the information on that. So currently, the influenza recommendations are for anybody over 65, people who are from 6 months to 64 years old if they have a high-risk condition, and strongly recommended for pregnant women. For COVID-19, we're trying to update the most prevalent vaccine, which is mostly the Omicron, which is circulating this year and is slightly different than last year. The RSV vaccine does not change from year to year. For the most part, vaccines are covered by insurance for all three, and the bottom line is never too late to get vaccinated. We like to emphasize this time of year, but that's not necessary. Influenza, which we call flu, COVID-19 and RSV are very highly contagious respiratory infections, but they are different viruses. The flu, which is influenza A and influenza B, is fairly seasonal. It peaks in the colder months, so October, November, December. Ideally, vaccination is September, perhaps early October, to provide immunity when the flu season does hit. COVID-19 is caused by coronavirus, SARS-CoV-2, and there are new variants which are seen each year. The impact is very significant, and especially for high-risk populations. So those that are immunocompromised, those who have other comorbidities. The vaccine, again, is not curative and it doesn't totally prevent, but it does improve the outcome of infection. Almost all three basically reduce the severity of infection. What we're trying to do is alleviate disabilities, being admitted to the hospital, or any other compounding any other infections. RSV is usually fairly mild, is more like a cold type of thing, but in very young babies as well as very older adults can be more severe, requiring hospitalization. All three viruses share some features, ranging, and they can present as asymptomatic, no symptoms, or severe symptoms. And a lot that depends on the person's susceptibility. If you're relatively healthy, probably not as severe. If you're a heavy smoker, not well-controlled diabetic, or have more severe cardiac disease, the symptoms can be more severe. Most commonly, symptoms are fever, chills, cough, short of breath, some difficulty breathing, fatigue, sore throat, runny nose, stuffy nose, muscle aches, and pains. Some people will have nausea, vomiting, diarrhea, but that's generally more common in children. Next slide. So how do these viruses spread? Mostly it's by transmission. So there can be droplets, which is by standing next to somebody who's ill, who's coughing, sneezing, or even talking, because they can project the droplets. Aerosols are more like just some heavy breathing, such as with exercise, speaking or singing, and that's much more common in COVID-19. Also through contact, if in other words somebody sneezed and you'd come by and touch a surface or any objects, then touching your mouth, eye, or nose, you can get infection that way. It also, as I mentioned earlier, can be spread before symptoms develop or people with only mild symptoms. There are also complications that are associated with the respiratory viruses, which include a bacterial infection, again, because your immune system is now debilitated because of the virus. We also see pneumonia, which can be a viral pneumonia or bacterial pneumonia, sepsis, respiratory failure, some neuromuscular weakness, lung cardiac complications, and unfortunately admitted to the hospital, which we hope to prevent with a vaccine. And very often we do see people who don't recover from their infections and actually pass away. Next slide. So in talking about COVID-19, we're looking at a forecast for the Bay Area. And this particular slide looks at 2 different weeks. So the right side is August 23 to 30. The next one is August 30 to the first week of September. So the one on the right, which is the earlier one, looked as though that middle line that you're seeing looked like there was an uptick. The blue spread is basically different models that try to predict what's going to happen. And you can see those are pretty much diverse. So from very high to very low. The projection on the right is the slightly more recent, which looks like there might be a downtick. But again, we're very early in the season and things can change rapidly. And a lot of things we see as much more infections when it gets to be colder. People are more indoors. With holidays, they're socializing more together, a little more travel. So we do expect this potentially to change further in the next few months. The next slide also shows you on a map of the intensity. So as of the right side, as of the August 26th, we were seeing the California, Oregon as what's called likely growing, so getting worse, compared to the slide that's on the left, which shows California has now gone to more of the green, dark green, which if you look down the levels is indicating this is declining. But again, this is very early in the season. It's a little hard to make those kind of predictions. We have not seen what the vaccine uptake will be, how compliant people are going to be. There's also a risk of co-infections with different viruses at the same time. And while this looks favorable, we strongly, strongly recommend that people still consider getting their vaccines when they're available. Next slide. This will go over the vaccines in a little more detail. So we'll talk about flu, respiratory syncytial virus, RSV, or COVID vaccines. These vaccines work to stimulate your immune system, which then produces antibodies, which provides protection. So it's some protection, not 100%, against the viruses. And the research indicates that these are the viruses that are going to be the most common for the upcoming season. So starting with the flu vaccine, this is the 2025-2026, protects against all 3 influenza strains, there are options. There's a standard dose, a high dose, which is recommended for 65 and older, and then an egg-free for people who have egg allergies. The COVID-19 vaccine targets the most prevalent variant, which is the Omicron, which is very slightly changed from the 24-25 vaccine. So the 25-26 looks somewhat similar, just a very minor change. There are 3 vaccines which are approved. One's an mRNA vaccine, which is produced by Pfizer and Moderna, and the more traditional virus blocking technology vaccine, which is the Novavax. All 3 are equally effective and can be obtained mostly through the pharmacies. The RSV vaccine, there are 3 providers, Pfizer, Moderna, and GlaxoSmithKline, and these are very similar. And this one doesn't change very much from year to year. And this is generally a single vaccine. It's a one-time, or at least as far as we can tell at this point, a one-time dose. Next slide. This goes over the 2025, 26 vaccine recommendations. So currently, annual vaccine for influenza is recommended for everybody over 6 months. Obviously, there has been some FDA recommendations that are varying a little bit. We're waiting for another committee update that will probably be mid-September. So currently, it's recommended for 6 months to 64 years if immunocompromised, over 65 in general, and less than 6 months is not recommended. So we do try to prioritize high-risk groups, elderly, pregnant, immunocompromised. There are egg-free options that are available. And in general, we don't recommend flu vaccine for people who have had an allergic reaction to a previous flu vaccine or have had Guillain-Barré syndrome. The COVID-19 vaccine is annual for most people, adults 65 and older, people 5 years of age to 65 with at least one high-risk condition. And again, these are being reviewed by the FDA and hopefully an update within the next few weeks. Pfizer's recommended for people over 5 years, Moderna over 6 months, Novavax for greater than 12 years. If a person has had an active COVID infection, we generally recommend waiting about 3 months, basically until your immune system has recovered in order to get the vaccine. The RSV vaccine is recommended for adults 18 to 59 with high-risk conditions like chronic heart disease, diabetes, emphysema, and then adults greater than 60, and definitely for pregnant women. The vaccine for pregnant women can transfer some immunity to the fetus, to the baby. So if the baby is born in an anticipated high-risk RSV season, getting the vaccine is definitely important for the protection and the health of the baby. At this point, we are not recommending a booster for the RSV vaccine, but the need for that is being reviewed. On the next slide goes through what Washington Health is doing in terms of prevention. Masking at the times of surges in infected patients. Mandatory masking is required on inpatient areas in the main hospital. In these cases with surges, including Morris-Hyman, the emergency room department, perioperative services, high-risk outpatient areas such as the infusion center, radiation oncology, and Washington Health pediatrics. And this is per Alameda County Public Health recommendations. Screening is done either self-screening as somebody is coming in for an evaluation to evaluate for respiratory symptoms prior to and on arrival. We isolate immediately any of our patients that are symptomatic. Surgical patients have mandatory COVID testing for surgical patients that are symptomatic or immunocompromised. We also recommend masking, but it's optional for visitors, workers, patients, and those not performing clinical procedures. But if anyone is ill, has had contact with someone ill, we generally recommend that they go ahead and do masking. On the next slide, I'm going over frequently asked questions. So people want to know, does the flu vaccine work? And the answer is yes. Again, it's not 100%, but does reduce the risk of severe illness by 40 to 60%. So the question is, do I need a flu shot and a COVID vaccine shot every year, even if I've had the infection? And again, the answer is yes. Even if you've had an infection, even if you've had a vaccine, protection for the immune system fades over time. And the strains do change from year to year. So the vaccines protect against the virus that's most likely circulating at each year at this time of the year. If you've had a recent COVID vaccine, you may want to delay getting a vaccine for about 3 to 6 months, again, unless you're at very high risk. The other question is, can you get all 3 vaccines at one time? And the answer is yes. I imagine your arm is going to be a little bit sore, and you may want to talk to your healthcare provider just to personalize the advice, but it is safe to get all 3 together. Generally, people want to know when should they get vaccinated. So end of October-ish, September, October-ish is appropriate for flu and COVID-19 vaccine if indicated. RSV vaccines are effective year-round, although they are, again, only one time only. The next slide goes over frequently asked questions. So how will the updated COVID-19 vaccine protect? It isn't meant to prevent every infection, but the aim is primarily to reduce severe illness, reduce hospitalization, and death. The 2025-2026 vaccine also boosts any prior protection that a previous COVID vaccine provided. Why do some people not feel well after a flu shot? Because a flu shot gives you some mild symptoms that seem like the flu, and there generally is some soreness at the injection site, which is generally because it's working. It's providing protective immunity, which is going to help your body fight against the flu. There are some occasional episodes where people have discomfort, fever, weakness that can last for 1 or 2 days after the vaccine, but generally these are much less severe than the actual flu illness and do get better with time. They also want to know, can the vaccine give you the flu? And the answer is no. The flu shots are made out of either inactivated virus or recombinant virus, neither one of which is infectious. So these are very safe and don't give people the flu. On the next slide, it goes over what can you do to help prevent the spread of viruses. So get your COVID-19 vaccine. We'll see what CDC and FDA recommends. Also for flu shot, we recommend it every year, again, pending what FDA and CDC are going to recommend. RSV vaccine, I would speak with your provider, and if recommended, go ahead and get that. The other thing you can do is good hand hygiene. Wash your hands, cover your mouth with your hand if you're coughing or sneezing, or if you're sick, stay home. Social distancing helps. Wearing a mask in high-risk areas help. If you do get sick, try to get care promptly. Most physicians can do televisits if you're sick, and they obviously would like for somebody who's really sick not to have to come into the hospital. So those are generally options that most physicians can provide. And again, if they recommend treatment, try to follow up promptly and don't delay treatment. The next slide says where you can receive most of the vaccines. So the COVID vaccine are available at most of the local pharmacies, and there are also test kits available at local pharmacies. In the past, they were provided by the government for free, but starting now you have to pay for them. So where can you get the flu vaccine? You can schedule it with your primary care provider or local pharmacy, and again, probably late September to early October is optimal. Where can you get the RSV vaccine? You probably want to talk to your provider to see whether or not the RSV vaccine is appropriate for you, but they are available at most doctors' offices and local pharmacies. So in closing, I want to thank my team, Mary Boron and Maria Nunes, Anusha Chakrabarty, and Shivali Desai. And they have been working behind the scenes for all of you for quite a long time and will continue to do so. So I'll take any questions.
Thank you, Dr. Martin. So I noticed that you mentioned about the after effects of the flu vaccine. Whenever I've had the COVID, I don't ever have any after effects from the flu vaccine. But when I had the COVID vaccine, I'm wiped out for at least a day afterwards. Is that common, or?
it's not uncommon to see it for 1 to 2 days, and it's actually considered a positive thing that your system is picking up what's being injected and making antibodies against it. So that can also occur with some people with flu vaccine, but we think that that's a positive. I know it's annoying and it's disruptive for your schedule, but it's actually considered a positive in that your immune system is responding.
No, thank you.
You're lucky.
And, Dr. Martin, I also want to just announce that Washington Health is doing a drive-through clinic on September 27th from 8 a.m. to 2:30 p.m. in Washington West parking lot.
Excellent.
So I just want to make sure that all of that's connected, and we have both regular and high dose for those.
Excellent. Okay. Yeah, we're just waiting for FDA to give us a little more guidance on what they think the recommendations are. Obviously, most people, from my perspective, want the more they get vaccinated, the better. Right now, they're sort of looking at a different projection. So we'll see what they recommend. But that's excellent that the hospital is providing that. It's just outstanding.
I have a question about the COVID forecast and the data. Looking at the slide that you had, the California Department of Public Health is using data as far as COVID-19 admissions, hospitalizations, ICU patients. We're not seeing much of that at all these days. And the other thing that I see is that I think patients are being a little bit more complacent when they get what may be a viral illness. They're not testing as aggressively as they would have a year or two ago. Even if they're positive, they may or may not be calling in for a prescription if they're feeling reasonably good. So I know there are other metrics for assessing COVID activities, such as monitoring the sewer effluent.
Yes, wastewater.
Activity. So where is the best data to tell us whether we're gaining or losing on COVID in our community?
The wastewater is definitely going up, so we're really concerned about it. At this point, I think it's a little bit early in the season because we're seeing people who are coming back from vacations, schools are getting started, people are coming back into the workplace. So I think we are at a point, sort of a balance between coming and going, and I'm fearful that we will start to see more intense season. Getting the COVID vaccine does prevent the long COVID infection symptoms, which is very devastating for some people.
Mm-hmm.
But good questions. Good questions.
I look forward to hearing more about how we're progressing with this. It's an ongoing saga.
Yes. I think we all would like to have that answer sooner rather than later. Thank you.
Thank you, Doc.
Then I mean, great presentation, but I think the only thing that I probably would add is the flu mist. I think flu mist vaccine is, I think, approved this year because I know it's not approved every year, and I know it's only from 2 years to 49 years age group, but I think it is approved this year. Yeah.
It's approved. It's generally very effective, but sometimes harder to find compared to the injections. And again, we're sort of waiting on the FDA to come up with the recommendations. So for me, more vaccines are better. They're looking like, well, we should probably target them a little better. So we'll see what they recommend.
Okay. Thank you, Dr. Martin.
Well, thank you for your questions. Thank you for letting me present this because we really want to get this out to the public in general. And for me, this is a very good way of reaching a number of people and providing information and your support. Thank you. I'm going to sign off.
And I know
comes up later. You can always contact me. Yes.
Great. Next, we're moving on to our financial presentation, and we'll start with the July financials. Ajay?
Promise this won't include any vaccinations. But maybe more people.
We just want to be immunized against loss.
There we go.
I like that.
You can figure that out.
We're trying to figure that vaccine out.
Okay. Work in progress.
Absolutely. Let me just start with a few comments and then I'll get into the data. Overall, July was a good start to the fiscal year. We had strong discharges, better average length of stay than budget. Surgeries were higher than budget, as were cath lab cases. Labor productivity and efficiency was good, and the hospital flexed well. Gross revenue was 1.3% better than planned. Contractuals and deductions are very close to budget, resulting in 1.2% higher net patient revenue. Operating expenses were also close to budget. That, of course, then results in a net operating income better than budget, although it's still a small loss. EBITDA was also better than budget. And having said that, if you have any questions, I'd be happy to take them, but if not, I can get into some of the details.
Go ahead.
Thank you.
Nice to hear all those good news.
Good news.
Stay tuned.
Yes, sir. Okay. Inpatient average daily census, we were a little below budget. Discharges were higher than budget. Patient days were a little below. And we continue to do well on observation days. And the average length of stay was better than budget. And most of this data you saw last month when Kimberly presents the operating data. The CMI was a little better than budget. Deliveries were, I think, 158 were one of the highest months. Surgical cases were better than budget. Cath lab cases were better than budget. Outpatient visits were better than budget. Emergency visits were a little lower than budget, but not that far off. On the surgical cases, again, 11 over budget. The main down were orthopedics. I think there were some physicians on vacation, as well as in urology and GI. And we did better than budget on cardiac, general surgery, and vascular. I think that one. Cath lab cases, we opened our account for the month, for the year really well, 43 above budget. 20 of those were in the cardiology cases. IR was 13 above budget, and neuro, IR, and vascular were 10 over budget. Moving on to the next slide, the productivity was also, the organization flexed well. We were almost 61.7 FTEs better than budget. And on an FTE per adjusted occupied bed, we were about 14 basis points better. On our deductions, overall, we were at 76.22 versus the budget at 76.25, relatively pretty close to the budget. On our GASB format, you will note here, this is where it all comes together. We had a net operating revenue of $56 million on gross charges of $231 million against a budget of $55.4 million gross revenue and the budget of $2. So all of that, so about 1.2% higher on the NPR. Operating expenses were almost flat to budget, 56.7 versus 56.8. That resulted in a net operating loss of $635,000 against a budget of $1.4 million. When we throw in on our non-operating income, that was about $708 behind budget, $708,000. Majority of that was the unrealized gain loss on investments, which, as you will recall, July was not a stellar month. overall, that's got us to a little better than budget, 55,000 better than budget on the net income, although we had a loss of 21,000 against a budget of 7. I was spending a lot of time on the FASB. It's pretty much the same information without that, the investment income. So it looks a little better on the non-operating income. And last but not the least, this page is, I like to focus on the EBITDA margin, and the EBITDA this is showing about 784,000 better than budget, and the EBITDA margin being 5.2% against 3.9%. So I'd say a good start to the year. And 1 out of 12, so we'll see how the next one.
I'll take it.
I'm not saying you sandbag the FTEs and
the spread may have had something to do with it.
No, I think it was an excellent FTE performance.
It really was. At the organization, given all the challenges that were being faced and moving units around and everything, they still did a great job on flexing. So I would agree.
All right, so I'll move on to August. Some of the numbers are, we had some strong areas. You will see our procedural areas, especially operating room, was down compared to budget, and I'll go through that. But also just want to note, and you'll see this throughout, is our length of stay dropped considerably, which impacted a lot of other metrics. So to begin with, again, looking at our outpatient observation days, came in at 198. And this is very aligned with the trend that we have been seeing, and it's favorable to the budget of 294. And I think, as I mentioned, we based the budget more on the August through March actuals and budgeted conservatively. So we'll probably continue to see that being better than budget. Moving on to total gross revenue trend, it came in at $224 million for August, which was unfavorable to the budget of $234.3 million by $10.3 million or 4.4%. And I'll get more into that, but it was mainly driven by lower inpatient gross revenue. And then also in terms of also with trauma, we saw less inpatient gross revenue. However, moving on to our trauma cases, overall, we had I think it was our busiest month in trauma, and 185 cases, and it was favorable to our budget of 154 by 20.1%. So it is the highest volume we've seen since we've opened. Inpatient trauma cases of 60 for August was favorable to the budget of 53 by 7 or 13.2%. However, the inpatient revenue per case of $201,000 was unfavorable to the budget by about $44,000. And this was really due to, we saw less ortho cases and less GI cases that came through than what was budgeted. So yes, it was busy, but we had a different mix than what we had been seeing. In terms of outpatient trauma cases, they had 125 that was favorable to the budget of 101 by 24 or 23.8%. Moving on to the next page, you can see how they broke down between alpha, the highest level of acuity, then Bravo and Delta. So 11 alpha, 45 Bravo, and 129 Delta. Out of the 185 cases, we had 61 falls, 61 that didn't have a chief complaint, 28 motor vehicle crashes, 10 medical symptoms, 13 body injuries, and then 20 others. So they're in the process of classifying some of those. Looking at our trauma gross revenue, it came in at $18.6 million for August, which was favorable to the budget of 18.1 by 0.6 or 3.1%. Inpatient gross revenue, as mentioned, came in at $12 million for August, which was unfavorable to the budget of $13 million. So it was less by about close to $1 million or 7.1%. Outpatient trauma revenue of $6.6 million for August was favorable to the budget of $5.1 million by $1.5 million due to more cases. Moving on and looking at our inpatient gross revenue, it came in at 131.2, which was unfavorable to the budget by 14 million or 9.7%, but was higher than August by about 5%. Again, in terms of, you'll see, but a lot of this was driven by room and board being under budget, along with surgical services and slightly emergency room and cath lab. Outpatient gross revenue came in at 92.7 million and was favorable to the budget by 3.7 million or 4.2%. And again, driven by a lot with ancillary services that we saw drove a lot of the outpatient growth. Looking at our inpatient average length of stay, I do just, this is the lowest that we've seen in a long time. It came in at 4.73 and was favorable to the budget of 5.22 by 10.4%. Just want to note a few things. August had fewer patients with stays between 31 and 60 days. So we had 5 patients that stayed that longer length of stay versus 8 in July and 14 in June. So that drove down some of that. Also, very important, we had no patients that stayed longer than 60 days and was discharged during the month of August. So if you remember when we discharged that patient in the month, that all of that hits the length of stay. So we didn't have any.
Is that the first time we've had that in quite a while?
Ajay, I think it's been a while. I don't know if it was the first.
For it to fall this much, there was a lot of data.
So just, 3 patients that stayed, like last month in July, we had 3 patients that stayed more than 60 days and one that was discharged that had stayed more than 150. So again, some of that. And also all the work, I also just want to say there's a lot of work that's being done in terms of really looking at the length of stay and trying to ensure that patients are staying the appropriate number of days. So I think it's a combination of many factors where we're seeing this. So I just wanted to mention that. Also, our length of stay per case mix index also came in at 2.91, also driven a lot. But looking at our discharges, they did come in consistent. So 1,080 was consistent with a budget of 1,087 and was also favorable to August of 2024. Patient day trends, so really trended with our length of stay. So they came in at 5,108. That was unfavorable to the budget of 5,672 by 564 days or about 10%. Again, really driven by that length of stay being a lot less than budgeted. Inpatient average daily census came in at 164.8, which was unfavorable to the budget of 183 by 18.2 or 9.9%. Again, a lot of that is driven by the lower patient days that we saw. Surgical trend, total surgeries in August came in at 523. They were unfavorable to the budget of 544 by 21 or 3.9%. Inpatient surgeries of 256 were unfavorable to the budget by 6 or 2.3%. And outpatient surgeries were also unfavorable to the budget by 15 or 5.3%. We did do 5 TAVRs in August. Moving on to the surgical activity, you can see the areas where we did not meet the budget. Neurosurgery and orthopedics are 2 areas. As I mentioned, we did not have as many orthopedic cases. We also had a couple of our joint surgeons that were out for some of that time during August. We are looking more into neurosurgery. We had a few canceled cases, so we're going back and looking at why those were canceled too. So we're doing a little bit more of a deeper dive on both neurosurgery and orthopedic. Cath lab for August came in at 217. That was favorable to the budget by 23 or 23.2%. For inpatient cases, they were favorable to the budget by 13 or 11.9%. And outpatient cath lab cases were also favorable to the budget by 10 or 11.8%. We did 3 microclips and 4 Watchmen that also performed during this month. On the next page, you can see the breakdown of the cath lab activity. Again, cardiac, interventional radiology, and vascular, all either meeting budget or above budget. Where we did see not meeting budget was neuro IR. So, we sometimes just see difference, what's mainly coming through the emergency room with strokes or other things. But both Dr. Razer and Thomas did the 1 or so cases each. Moving on to deliveries, continued to have a busy month in deliveries. We came in at 143 cases compared to a budget of 137, so we're up by about a little over 4%. We also, our C-section rate was 27.3% of total deliveries, and was less than the prior month. So continuing, as you know, to work on that. Our non-emergency department outpatient visits, they were favorable to the budget by 391 or 4.4%. We really saw that across the board in terms of increases in from outpatient room to x-ray, diabetes, education, and rehab. So across many areas that we saw higher than budget for the outpatient visits. In terms of our emergency room visits, they're pretty consistent with budget. They came in at 5,365, so consistent with the budget by 20 or 0.4%, and favorable to last year, 2024. So we continue to see a little bit less in terms of critical versus different levels of acuity, but overall pretty consistent. Going into the gross revenue recap, as mentioned, we did our surgical services revenue, you can see, is unfavorable to budget by 8.8%, and we were 3.9% unfavorable to the budget in terms of cases, but really looking at orthopedic and neurosurgery are two large drivers, so that's why that case mix impacted surgical services. I do want to just mention cath lab, as you know, we were over budget in terms of cases, but we did end the month on a Sunday, and then the next day was a holiday. So we do have close to $2 million in charges that will be posted in the next month because of that. So that's why those two with the volume and the charges are not quite aligned. But just want to mention that piece. Room and board was unfavorable to the budget by 13.5%. A lot of that's due to lower patient days. You can see with emergency room was a little bit less than budget at 4.2%. Birthing center was up given the volume. Preliminary payer mix, overall in terms of our Medi-Cal was below budget, and Medicare was a little bit favorable to the budget. So you can see we came in at government payers at 72.7 versus 73.5. Otherwise, our HMO and PPO was pretty close to budget, along with self-pay. TRICARE was a little bit above budget at 1.5%. In terms of our productive FTEs, we pretty much were very consistent with budget with the flex by 5.5 or 0.4%. If you look at non-productive, we came in just slightly favorable to the budget by 7.2 or 3.6% on non-productive. And then looking at our total FTEs, they were pretty much, again, right on consistent with budget, with flex budget by 12.7 or 0.7%. We did our total FTEs per adjusted occupied bed, pretty consistent with the budget at 6.03. So that, moving on to some of the other entities, Ross Treatment continued to be below budget at 260, though we continue to see more complex types of cases with 139 IMRT and 5 SRS. But we are continuing to watch that. It is similar to August of last year too, that it came in at 264. We did have, if you look at the next page, 33 new referrals that came in for the month. And so we saw also 24 new patients were seen at the Rock in the clinic. We had a conversion of about 18%. So it has been a little bit lower, but we are watching it now that we have another medical oncologist that's joined the team, and she's getting up to speed. So we're looking to see that volume over time. Washington Health Medical Group, basically the visits came in consistent with the budget by 73 or 0.4%. Both primary care and specialty care were pretty consistent with. Looking at our development corporation, we came in favorable to the budget by 73 or 3.2%. I do want to say our Washington outpatient rehab visits were favorable to the budget by 8.2%, and that helped to offset WASC and PSC, or two ASCs, were below budget. WASC was mainly below budget in gastroenterology. We had one of our GI doctors that was out for a long period of time, so for a number of weeks during that month, so that drove volume to be lower. And then also in PSC, one of our main orthopedic doctors was also out. So, moving on to key financial statistics, we came in at 110 days for August. There were a couple of main drivers of this. We did process a $3.6 million pass-through of supplemental payment revenue, so the IGT. We will be getting back in November about 2 to 3 times that amount, so that will be coming in. As you know, we provide that and then we get it back in a sense that it is a couple of months later. Also, we had a number of capital expenditures for a lot of our construction projects, especially the infill project, and so we will be receiving $5 million in September from our general obligation bond to support that. So if you took those two, we would still be about 118 days if you looking at that. So our accounts receivable days were at 56.15, which is the lowest we've seen since November of fiscal year 24. So we've been focusing a lot in terms of cash. So overall, you know, in terms of seeing kind of where we stand with the payers is going to be key to seeing where we are with our financials for August. Any questions?
We're seeing a consistent trend in the deliveries being higher. Do you understand what's behind that? Is it St. Rose, or
some of it is
more than St. Rose?
Some of it is St. Rose. Also, I know that there are a couple of new providers that have joined, like the Palo Alto Medical Group too.
Mm-hmm.
So I think it's a combination of a few things too. So, and I know we're also our medical group has been working to grow volume there too. So I think there's a lot of work that's really being done in terms of integration between the clinic and our unit. Mm-hmm. So I think that has helped a lot. We've broken down a lot of some of those barriers in terms of so they're not working in silos. There's a lot more integration at the system standpoint.
Good thing to see.
It is good. There's still work that needs to be done, but yeah.
Okay.
All right.
Any questions?
All right, I'd like to move on to our Employee of the Month for September, Nancy Liu. She's a clinical dietitian with certified diabetes care and education specialist. She has been part of Washington Health in the outpatient diabetes education clinic for 3 years. She completed her undergraduate studies at UC Davis, where she majored in clinical nutrition. After completing her Golden Gate dietetic internship, Nancy passed the registered dietitian exam and began working at the San Francisco VA hospital. Working in the outpatient diabetes clinic, Nancy uses her knowledge as a clinical dietitian to assist patients in developing skills to improve their lives while living with diabetes. Her great attitude, strong empathy, and ability to communicate complex nutrition topics in an easy-to-digest manner makes her very well liked by both patients and coworkers. Nancy finds her work extremely rewarding. She says, I enjoy connecting with patients and helping them to develop a better relationship with food. Nancy also notes she is happy to see patients build the confidence they need to make good nutrition-related decisions. Nancy works with different types of diabetes patients, including type 2 and gestational diabetes, as part of her goal is to find the right approach for each patient. She knows that building a relationship with those ongoing patients will help them to be more receptive to her input. Nancy delivers patient-centered care by listening to what each patient is looking for and tailoring information to their goals. She has worked closely with our diabetes leadership to streamline the organization and visualization of essential program data. She worked hard to develop necessary skills to excel in her role, and she attends conferences and remains active within professional organizations. In addition to her daily duties, she commonly holds classes for the community on a variety of nutritional topics, which include general healthy eating, nutrition for diabetes, and most recently, classes for the cardiac rehab program. She is one of 4 girls and has a twin sister. She loves to travel both within the U.S. and internationally, including trips to Japan and Iceland. Congratulations to Nancy Liu. We're happy to recognize her as September Employee of the Month. A lot of wonderful things that a lot of coworkers said about her, so I have to say that. Yeah. All right, I'll move on to our health promotion and community outreach events for the month of August. We were out in the community and very busy, as you can see. For August, we were at the Festival of India. We also, on the 21st, Maria Nunes, our nurse practitioner, was at the Mark Green Sports Center in Union City. And also we hosted open house, as we mentioned, for Dr. Jasmine Yoon, who's our new medical oncologist that recently joined. And then also on August 26th, Garrett Cords was in our injury prevention coordinator, was at the Masonic Homes talking about drive safer, drive longer. You can also see in terms of coming into September, we talked about our WOOF canine therapy program at Niles Rotary. Also, September 9th, Maria Nunes was doing the Washington Health Walk at Diabetes in Union City. And on September 10th, Christy Caracappa talked about, for Medicare, what you need to know on Facebook and YouTube. You can see some of the pictures. Moving on, there's a lot in terms of the community. You can see we're going to be on September 13th, Walk to End Alzheimer's at Masonic Home in Union City. We'll also be on September 17th, Polly's Heart Health there in Union City at the Ruggieri Senior Center. And also we'll be at Newark Days Parade in Newark, and then also at the New Haven School Foundation Let's Shut, both on September 20th. There's a lot of different things happening on the same days, as you can see on the 21st. Also the Newark Days Parade and Community Health Fair, Information Fair, and the Fremont Disability Resource Fair. Then on September 25th, also Maria Nunes is out talking about signs and symptoms of stroke at Acacia Creek. And also we will be at Federico's Grill, celebrating Kiko's birthday memorial event. Really, again, talking about the importance of choking, first aid, and education, and how important that is for our community. You can see moving into October, Community Safety Fair. I know Kayla mentioned that on October 4th. We're going to be here at Washington West. Also on October 4th, Dr. Seema Sehgal was mentioned. She is the honorary chair for National Alliance of Mental Illness and their walk that is happening in the park. And we have Dr. Upender on October 8th that's talking about on Facebook and YouTube breast cancer screening, the impact of 3D mammography. And just want to finally remind everyone, on Saturday, October 11th is our 39th annual Top Hat. Proceeds will go to our robotics program, so if you haven't bought a ticket, make sure that you do. That is it for that.
Well, thank you. Any questions or comments? All right, then, we are gonna move to, the remaining action items, for tonight. Consideration of BRG consulting.
I'd like to talk a little bit about that, yes. I'd like to, we are recommending strongly moving forward with Berkeley Research Group, otherwise known as BRG Consulting, to help us really looking at revenue cycles. It is something, as our organization has evolved and grown, it is something that's very important, is to look at all aspects of the revenue cycle. And having a third party come in and help us look at best practices is really something that we want to do. It would be a 22-month agreement. We would be really focusing on optimizing our revenue cycle, looking at people, processes, and also technology, and making sure that there are areas that we can use technology to help us. That is something that many places are starting to look at. They will focus on revenue strategies, patient financial engagement, payment variance, and also technology, as mentioned. So, there's really three components to this. The first is a fixed fee. It would be a total of $3,080,000 for over 22 months, and it would be paid out at $140,000 per month, each month for 22 months. The second is really a contingency incentive paid, and it's really based on what we realize, and we won't pay this out until it's actually demonstrated that we've actually realized it. And there's two pieces to it. There's actually net revenue, so new net revenue that is coming in, and then there's also just cash acceleration, so being able to collect that cash sooner. And so we worked with BRG looking at sort of a low, medium, and high range, and we're really looking at more of the medium, hitting the medium range, and that's what this is based on. We really want to try to exceed that, but really want to come to the board and ask for incentive based on that. So looking at that, if hitting that at over $50 million, there would be additional incentive pay that would be going to BRG at $5,631,000. And then we're also requesting an increase of $500,000 for information services, and that additional for support and technology over the next 22 months in supporting this project. I do really feel this is an important initiative and something for the health system. It will touch all aspects and all of our entities within the health system, and it is something that we really need to focus on, ensuring that we are appropriately collecting the work that we do.
Mm-hmm.
So.
When do they start?
October. If the board moves forward, we're starting in October. Yeah.
Assuming that it's approved. That's our goal, is to get them here as soon as possible, no later than October 1st.
Other recommendations?
Thank you. Any questions?
Mr. President, I move that the board authorize the Chief Executive Officer to proceed with entering into the support services agreement with Berkeley Research Group, or BRG, as she said, comprised of a fixed fee of $3,080,000, a maximum midpoint contingency fee projected at $5,631,000, and an additional $500,000 to support required technology enhancements.
Joe?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Glad to see that.
Thank you.
Glad to see that.
Yeah.
Yeah, thank you very much. I know
Appreciate it.
we've got a lot of work that we feel really, very much.
Well, they uncovered some stuff.
Yeah, good, yeah.
Best practices in the area that we really need to focus on.
Okay. Anything else? Any announcements? Anybody got anything? All right. Seeing there is nothing more, this meeting is adjourned.